This is the second in a series of presentations on radiography of joint disease in veterinary patients. The intent of this presentation is to describe and provide examples of the most common degenerative disorders affecting the stifle and shoulder in the dog. And by the end of the presentation, you should be able to identify, describe, and hopefully diagnose cranial cruciate ligament disease and bicipital tendinopathy. Let's start with cranial cruciate ligament disease, which is the most common cause of stifle osteoarthritis in the dog. This is often a degenerative process rather than occurring from a traumatic event. Any age, sex, or breed can be affected, although it is more common in large breed dogs. And in fact, you should know that the cat, horse, and cow can also present for this disease. Patients may present with chronic or acute signs, and they may have a partial or complete tear of the cranial cruciate ligament. Even when they present with acute signs, they have oftentimes had degenerative changes to the cranial cruciate ligament and maybe a partial tear that then completely and acutely ruptures, and that is the cause of their acute signs, rather than it being truly a traumatic event. When we look at the patient that has cranial cruciate ligament disease chronically, we oftentimes can find degenerative changes. There are some radiographic findings that can be suggestive of cranial cruciate ligament, although none of the degenerative joint disease is particularly specific. So what are we going to look for? This is a lateral view of a stifle, and one thing that is most commonly present is joint swelling. So if you look, we have some intracapsular swelling of the stifle joint in this dog. Remember that there is a more lucent fat opacity of the infrapatellar fat pad, and that fat pad actually goes really close to the joint articular surfaces. And in fact, usually the soft tissues of the joint will not go beyond this margin of the condyle. So as soon as you see soft tissue going up to the level of the trochlear ridges, then we should start to think that there's probably some swelling. This intracapsular joint swelling may be effusion, but it may also be some hypertrophy or thickening of the joint capsule as well as effusion. We can see osteophytes because we're looking at a more chronic patient with degenerative joint disease oftentimes. And those osteophytes, remember, are periosteal proliferations that will be on margins of the joint. So specifically on the patella, proximally and distally, we may see little irregularities from osteophytes on the fibula. And then one specific area that I want to draw your attention to is when we get enthesopathy, and remember that was a term of periosteal reaction at the origin or insertion of tendons, ligaments, and capsules. When we get enthesopathy, which is this proliferation here, that is a periosteal reaction at the insertion in the area of where the cranial cruciate ligament is. When I see this enthesopathy, that is going to really make me suspect that the arthritis of the stifle is from cranial cruciate ligament instability or disease. Sometimes we will see that there is an unaligned joint because they can have like a tibial thrust or a cranial drawer, and then sometimes we can see periarticular ossified bodies. This is the same lateral view of the patient without all of the labeling, so you can see that there is this increased soft tissue opacity of the cranial aspect of the stifle joint. It is kind of compressing and displacing this infrapatellar fat pad. This soft tissue line here, this soft tissue opacity, is our patellar ligament. So this is soft tissue swelling of the joint in the cranial part. And then when we look at the caudal part, there's a normal fascial plane here that should have fat opacity that should separate the joint space from the gastrocnemius muscle belly. And in this case, the joint swelling caudally here is kind of distorting and displacing that fat pad. I've already pointed out some of the osteophytes. On the cranial caudal view here, we can also see some osteophytes here on this medial fibula, as well as a small amount here on the medial femoral epicondyle. And then this patient also has some soft tissue swelling that is more of extracapsular swelling because it is localized here to the medial side, which is medial buttressing that is very common, which is thickening of that medial aspect of the tissues in the joint capsule in patients that have chronic cranial cruciate ligament disease. Here's another patient that has a couple additional findings. So here are osteophytes that are at the proximal aspects of these trochlear ridges. Sometimes you'll see sclerotic lines of osteophytes along the trochlear ridges. This patient has a little bit more osteophyte formation on the fibella. Also has the intracapsular soft tissue swelling or joint swelling of the stifle, has a little bit of that periosteal reaction, which is the enthesopathy. And the term enthesopathy actually comes from enthesis, and enthesis is the cartilage that is between the tendon, ligament, joint capsule, and the bone. This patient finally has this kind of oval, mineralized or ossified body in the cranial aspect of the stifle joint. And when we see these ossified bodies, most of the time it's probably from dystrophic mineralization of the cranial cruciate ligament or perhaps of the joint capsule. It is possible that where the cranial cruciate ligament inserts, it may have caused a little avulsion of bone when it ruptured, or it's possible sometimes that these periarticular ossified bodies are broken off osteophytes. The other soft tissue that is within the joint of the stifle is the menisci, and sometimes the menisci can have dystrophic mineralization, and we'll see those as ossified bodies. Now, I did mention that we can look for normal or abnormal alignment of the stifle joint, and the next two slides discuss that. This is a close-up magnified view of the lateral image of a stifle in this patient. And this patient, I want you to notice, has been put in a special position for its radiographs. This is called the TPLO view, and TPLO is standing for the tibial plateau leveling osteotomy, one of the surgeries that they can do for this disease. And what that means is that the stifle is in 90-degree flexion and the tarsal crural joint is in 90-degree flexion. And basically, when you position the patient like this, it is putting them into tibial thrust. And so we can look for alignment or lack of normal alignment. This patient has some osteoarthritis changes from cranial cruciate ligament instability, and there is intercapsular soft tissue swelling of that stifle. There are osteophytes here, proliferation, and then some sclerosis on the trochlear ridges, the distal patella, the fibellae, and this patient has that osteophytosis here in the region of insertion of the cranial cruciate ligament. So that is our enthesophytosis or enthesophyte formation with some subchondral sclerosis. Now, this patient has normal alignment. If you look at the image on the right of our screen, how we tell alignment is first we take the femoral condyle from the lateral view and we basically divide it into three pieces of a pie. So this line is just going across the physeal scar here, and then I've just divided that condyle into three equal pieces. Then we need to identify a specific structure on the proximal tibia, and that specific structure is the intercondylar eminence. And if you look on the unlabeled image, these two little bumps right here are the bumps of the intercondylar eminence. And in normal alignment, the intercondylar eminence will be lined up with kind of the middle third of that condyle. So this patient has stifle swelling and degenerative joint disease from cranial cruciate ligament instability, highly suggested by the enthesopathy here at the insertion site, but has normal alignment. Now let's look at this patient. This patient is also in this tibial plateau leveling osteotomy view, so 90-degree, 90-degree. When we look at our close-up view and we look at our alignment, we can see that this patient is actually not aligned. So again, we're going to draw a line across that physeal scar and we're going to divide the condyle roughly into thirds. And we're going to look for this intercondylar eminence. And in this patient, we can see that the intercondylar eminence is actually lining up with kind of the juncture of the more cranial and middle third. If you go back to the last patient, it should be in kind of the middle of the middle third. So this patient actually has a tibia that is too cranial relative to the femur. Remember when we learned about displacements with our fractures or with our joints, we talk about the distal limb or the distal portion of the limb relative to the proximal portion. So this tibia is too cranial relative to the femur. This patient also has marked intracapsular swelling of the stifle joint, also has a large osteophyte on the distal patella, and then has just a teeny little bit of filling in of bone from enthesopathy here. So typically this area should have a nice little mountain and then a valley and then another mountain. And so there is a little bit of smoothly marginated enthesopathy. So this patient we know is definitively with an acute or a complete rupture of the cranial cruciate ligament. Now, again, unless we can see that there is not good alignment, there really isn't anything extremely specific for cranial cruciate ligament instability. However, there are typical sites for osteophytes that we need to assess. And once you start to find that the patient has degenerative disease, then we can start to be even more suspicious of the most common cause being the cranial cruciate ligament instability or disease. So areas of osteophytes on the lateral and the craniocaudal view where we'll look. First of all, the femoral trochlear ridges. This patient has some osteophytes on the proximal part. We'll look on the patella proximally and distally. So notice there is projection of new bone. So that's our periarticular osteophytes. We'll look on the fabellae. So typically these are fairly smooth ovals. This one has some projecting distally osteophytes, which we can also see on this craniocaudal view as these little points. The femur oftentimes gets osteophytes on the epicondyle. So here is proliferation or osteophyte production on the medial epicondyle and just a little bit on the lateral epicondyle. And then a final area of the osteophyte formation is on the tibial condyle, so the proximal tibia. Here are these little points of bone, which are our periarticular osteophytes. To me, when we look at that proximal tibia, kind of looks like there's little devil horns or maybe pagoda. So some people call that the pagoda sign. And then this patient also has this enthesophytosis or enthesopathy at that origin of the insertion of the cranial cruciate ligament. So all of these degenerative changes are nonspecific, but when you find this enthesopathy here, you really should be thinking cranial cruciate ligament disease. This is just a slide that talks about when the patient truly has an acute rupture of the cranial cruciate ligament. So in acute rupture, so no underlying chronic degenerative change to the cranial cruciate ligament. So this would be with a traumatic event. We typically do think about seeing some intracapsular soft tissue swelling of the joint. However, that joint swelling is variable, and sometimes, especially if it's early on, before there's kind of a response, it may be pretty minimal. In this case, if we look at this patient, I think we can see that this tibia is very cranial relative to the femur. So this is the intercondylar eminence. And remember, if we're in a TPLO type view, which this one is, that intercondylar eminence should be lined up in the middle third of the condyle. Now, one thing to be careful of is if you are not in that TPLO view, just kind of a neutral lateral view, then you can't use the intercondylar eminence. So it really is specific for that view. However, if it were this cranial to the femur, that would still tell us that this is an acute rupture. And then if it truly is acute, we shouldn't see any bony osteophytes. So look at how smooth these trochlear ridges are, the patella, the fabellae. There's no extra bone anywhere and no enthesopathy at the insertion of the cranial cruciate ligament. Next, I wanted to talk about disease of the bicipital tendon or bicipital tendinopathy or tenosynovitis. And this can occur secondary to a traumatic event or strain of the biceps. Sometimes the tendon will actually rupture. And then the other potential is that there is an ossified body that is loose within the shoulder joint. And in the dog, anyway, the shoulder joint communicates with the bicipital bursa. And so if a joint mouse migrates into that bursa, it can get entrapped and it can cause disease to the biceps tendon. Middle-aged large breed dogs are most commonly affected. However, other species like horses can be affected as well. Additional imaging procedures such as ultrasound or MRI are necessary to fully characterize the lesion. The radiographic changes are only, suggestive of. And in addition, the MRI and ultrasound will look for additional soft tissue lesions that may not be associated just with the biceps. And so these are just two images over here, a coronal plane and a sagittal plane of a shoulder that is of an MRI procedure, where you can see that we can actually now see all these soft tissues and even the joint fluid along with the bones. So it's very beneficial. Ultrasound is more available, and so many people will use ultrasound in small animal patients as well as large animal patients. There are radiographic findings that are suggestive of biceps tendinopathy. Again, not specific. However, some of them can be, pretty highly suggestive. Typically, I'll find these on the lateral view of the shoulder. This patient, the suggestive findings would be if we look in this intratubercular groove of the humerus, so that is where the biceps tendon runs. This patient has a line of sclerosis or increased bone opacity. You'll notice that this will not be present if you compare to a normal lateral view of a shoulder. So this is bone sclerosis. Sometimes it's actually proliferation on the outer side into that intratubercular groove. And then the origin of the biceps tendon is on the supraglenoid tubercle. And so depending on the type of underlying, trauma or strain, you may actually see some enthesopathy or periosteal reaction on that supraglenoid tubercle. And then more often than not, these patients actually have osteoarthritis of the shoulder as well. So this patient has large osteophytes on the caudal aspect of the glenoid and the caudal aspect of the humeral head. So these are oftentimes seen with biceps tendinopathy, but this is really shoulder degenerative joint disease. Here's an example of a patient where I've provided both lateral and craniocaudal views. This patient has findings that are suggestive of bicipital tenosynovitis or tendinopathy. The main thing that I can see is this region of sclerosis in the intratubercular groove. On the craniocaudal view, this is the region of the intratubercular groove, and sometimes you might get the impression that there's some sclerosis there, but this view, everything's superimposed, so it's not as helpful. This patient may have a tiny little osteophyte on the caudal aspect of the glenoid and the humeral head, so probably has a minimal amount of shoulder osteoarthritis. One thing I want to point out on the craniocaudal view is that the shoulder joint in this patient looks quite wide at the medial aspect. In this patient, this is probably a true finding, but in some patients, you'll see some incongruency on this view because the shoulder joint, remember, doesn't have true collateral ligaments. So the muscles and their tendons are acting as the collateral ligaments. And so there's a little bit more play or laxity in that joint. And so if we aren't holding them in straight positioning, you'll sometimes see some incongruency. However, this patient probably does have some medial instability, which can be part of, just kind of rotator cuff injury that can happen in our dogs. And so sometimes you'll also see a little bit of irregularity out here of kind of enthesopathy osteophytes if there is damage to that medial compartment. This is just a labeled slide for your use for studying. Here's another patient that has some more extensive changes. I have, again, a lateral and a craniocaudal view. On the lateral view, not only is there some sclerosis here in the region of the intratubercular groove, so again, this increased bone opacity. Here's our lesser tubercle, lesser tubercle, and our greater tubercle. The greater tubercle at the base, there's also quite a bit of increased opacity, which is probably a combination of sclerosis and periosteal reaction. On the caudal aspect, there's a little bit of an osteophyte here that's maybe a little bit separated, so it could be broken off. Sometimes they get a little bit of dystrophic mineralization in the soft tissues, and then there's a small osteophyte on the caudal humeral head. On the cranial caudal view, notice this patient has more congruent joint here. This is that mineralization out here on the medial side, kind of surrounding that intertubercular groove that I see on the lateral view. In that patient, an additional view can be beneficial to help us decide where that mineralization really is. Is it somehow associated with the intertubercular groove still, or is it associated with the greater tubercle? And that additional view is a kind of flexed skyline view of the bicipital or intertubercular groove. And if you look at the image on the right here, the photograph is of us making this radiograph in a patient. So you notice that the cassette is actually placed on the cranial aspect of the shoulder joint. The shoulder joint is in flexion. Notice the cassette is kind of placed in between where the elbow is in flexion. And then the x-ray beam is coming from dorsal to hit that cassette. And so we're actually getting a skyline view over the point of the shoulder. And that skyline view looks like this. This is the medial side where the humeral head is. This is the lateral side. And so we have a lesser tubercle and a greater tubercle. And the intertubercular groove is in between those two tubercles. In this patient, we can see quite a bit of mineralization that's actually in the region of that intertubercular groove. And so that's probably entrapping and further damaging that bicipital tendon. Here's a patient that has a different disorder, and I just wanted to show you this and see how it looks different from the biceps tendinopathy. On the lateral view of this patient, notice that there is this kind of periarticular ossified region. This is too cranial to be within the region of the biceps tendon. So again, the biceps tendon originates on the supraglenoid tubercle, runs through this intertubercular groove. This mineralization, too cranial, is actually mineralization within the tendon of the supraspinatus muscle. And so this is a different disorder that can occur at the same time as biceps tendinopathy or occur separately, and that is supraspinatus ossifying tendinopathy. Both of these disorders can lead to shoulder lameness. The textbook that I've listed here in chapter 21 does provide limited additional information if you would like to see another example and read a little bit more about degenerative joint disease affecting the shoulder and degenerative joint disease affecting the stifle.